We're here today with Cara, Camiolo, Reddy for a rapid-fire session of 37 questions about Intermountain's initiative to reduce opioids. I'll start those questions right after this one. You ready for this?
I'm ready. If you stand back there, I'll take my mask off.
What's your name?
My name is Dr. Cara, Camiolo, Reddy.
What's your title, Cara?
I'm the Senior Medical Director for Pain Management and Rehabilitation Services.
And you're a doctor by training.
I am.
So what in your background qualifies you to talk to providers about reducing opioids?
I've been a rehab doctor for nearly 20 years. I've taken care of a lot of patients with pain and talked to them about the effect it has on their life. In addition, as Senior Medical Director, I've worked with a lot of providers to talk about the challenges of prescribing opioids in their practice and helping to create policies and procedures to make that practice safest for patients.
So how is Intermountain doing when it comes to reducing opioids?
Very well.
How do you know we're doing very well?
Well, since 2017, since we have been tracking the number of pills prescribed in our communities, we've reduced the number of opioids by over 6 million.
That sounds like a lot of pills not in our community. Does that make us safer?
It does, and it means that there's less chance of accidental overdose, as well as less pills hanging around for people to find in their medicine cabinets.
So we've seen success in tackling opioids head on.
We have.
Why change strategies now?
Well, the data shows us that we have additional opportunity.
What data are you seeing?
Well, what we're finding is that people may not always understand the difference in potency of opioids. And so we have an opportunity to begin to reduce the MME.
What is an MME?
Morphine milligram equivalency.
Okay, what's a morphine milligram equivalency?
Well, as we said, not every opioid is created equally. And so sometimes it's like comparing apples and oranges. They have different potency, they have different dosages. But an MME allows us to give it an equivalency so that we can compare apples to apples.
So why is it important to get that equivalency, the total daily dosage of opioids?
Well, because as the MME increases, the risk to the patient increases.
So how are prescribers tracking opioids?
Well, right now we have developed a new dashboard that's going to allow us to identify the MME that are being prescribed into our community.
You mentioned that not all opioids are created equal. Can you tell us more about that?
Well, let me give you an example. Fentanyl is more potent than oxycodone, and oxycodone is more potent than tramadol. And if patients don't understand different potencies, then they may not understand the risks that they have.
So just reducing pills doesn't capture the whole picture.
That's exactly right.
So when will we start hearing more about MMEs?
Well, this conversation is the beginning. In the coming days and weeks, we're going to start to hear more about MME.
So prescribing opioids, it's necessary for people in acute and chronic settings. How can we take extra steps to avoid unnecessary harm or injury?
Well, I think the first thing to remember is that there are non-opioid pain treatments and interventions that should be considered first. And in the acute setting, opioids sometimes are the best treatment, but it's important to start low and go slow.
So how should providers use the total daily opioid dose in clinical practice?
Well, it's important that we double check, that we prescribe the lowest dose effective for anyone's pain.
So what if the lowest effective dose is still high?
You know, that's common. But I think what's important is making sure that we continue to talk with our patients, we ask them about their pain, and we also monitor their function.
Do you think we should stop prescribing opioids?
No, not exactly. It really is up to the provider's best judgment, but we have to be mindful that stopping opioids altogether can also be really harmful for patients. And if we don't have conversations with them and we force them into tapers that they may not be ready for, studies have shown that they then go to find opioids in potentially unsafe places.
So you're saying that higher dosage means higher risk?
It does.
Doesn't higher doses reduce more pain?
You know, not always. Sometimes as the dose increases, patients can develop what's known as hyperalgesia, or actually more pain as the dose of opioids increase.
Do you think that physicians and advanced practice clinicians are concerned about opioids?
No, I do.
Why do you think they're concerned?
Well, I think everyone recognizes that patients are at risk and that we need to be providing the safest care possible.
Do some prescribers think opioids are a quick fix to pain issues?
You know, maybe several years ago that might have been the case, but we've learned a lot about opioids recently. I think everyone understands the risk.
So how can prescribers be cautious when prescribing opioids?
I think the most important thing is understanding the MME and being able to have conversations with their patients about the potency.
So opioids aren't a first-line treatment for chronic pain.
They're not.
And we still try and stay away from prescribing benzodiazepines and opioids together, right?
I think that's a really important point, yes.
Why is that again?
Well, both benzodiazepines and opioids have the chance to suppress breathing, and in combination, the risk of unintended overdose increases quite significantly.
So benzodiazepines and opioids together lead to more emergency room visits.
Yes, absolutely.
So you're saying that MMEs are all about patient safety.
This is.
So helping prescribers to use MMEs is what's best for your patients?
It is.
Are you trying to stay on top of things?
Yeah, and that's where the tools that we're developing and the dashboards that we're developing that will give us the information necessary about MMEs will allow us to have conversations with providers to better inform them about the risks.
So you're trying to let the data speak for itself.
Well, it sure does, but even good data needs a spokesperson. And so our pain management team is really going to be out there and talking about MME.
Calculating MMEs for each patient sounds like a lot of work. How are you trying to make calculating MMEs easier for prescribers?
You're right, it can be a lot of work. And so we want to make sure that providers have tools readily accessible to them that can make this easier. And so in the next several weeks, you're going to see additions to Icentra that's going to provide an opioid alert that will show you the MME of the prescription. It will also give you a risk calculation to show you the risk to the patient of that opioid prescription. And lastly, we're hoping to integrate the controlled substance database directly into Icentra in ways that make that information accessible in the patient's chart.
It sounds like you've really thought this through. How will you know if the shift to tracking MMEs is working?
Well, we really want to make sure that patients are safe and that providers have the tools necessary to provide that safest level of care. If we can do those two things, we've been successful.
And that's where we're focusing on MMEs to help people live the healthiest lives possible.
That's right. Whether it's picking up your grandkids or picking up the groceries, pain can be a significant impact in people's lives. And it can be because of a car accident or because of cancer-related pain. We want to be sure that the safest care is available to our patients, but also that our providers have the tools necessary to do that.
Thanks, Cara. We'll let you get back to work now.
Thanks.